Hello, I'm Dr. Marla Dubinsky from the Icahn School of Medicine, and welcome to our program, Current Challenges and Emerging Approaches in IBD Management. I'm delighted to be joined by my friend and colleague, Dr. Ed Loftus. Welcome, Ed.
Hi, Marla. Thank you for having me. I'm Dr. Ed Loftus. I'm a professor of medicine at Mayo Clinic College of Medicine and Science in Rochester, Minnesota. And I'm glad that you all could join us today.
Yes, we have a lot of great stuff, I think, to talk about, so I'm excited to share that. Our faculty disclosures are displayed on the screen. Our program tonight, which I'm delighted to be co-chairing with Ed, is to cover the unmet needs in our patients with ulcerative colitis, the latest data on small molecule therapeutics for UC, and a patient case study. So first, I want to note our learning objectives for today, which are here on the slide. Obviously, recognize the prevalence of suboptimal outcomes first. We're going to review where we are and how patients are doing on our current therapies, understand the value of routine monitoring, evaluate the benefits associated with earlier introduction of new targeted therapies in the management of ulcerative colitis, apply clinical trial data to clinical practice, and incorporate new and emerging IBD therapies once they became available to improve patient outcomes, and develop an evidence-based treatment selection protocol and incorporate patient preferences into shared decision-making for the successful management of inflammatory bowel disease. So before we actually get and dive into the slides, Ed, I'd like to kick off tonight's program by talking about the current unmet needs in our patients with ulcerative colitis. So I'd love to know, sort of, if you had to say 39,000 feet, where are we in thinking about IBD treatment, and what has changed, and where do we need to go, and where are we today?
Yeah, there are a lot of unmet needs. I think one of the issues is, for mild disease, we have medications like the 5-aminosalicylates, various mesalamine preparations or valsalazide. But sometimes I think we drag our feet and we don't make that jump to the more advanced therapies or biologic therapies. And I think there are patients who sometimes languish, right? And so we need to, I think about the targeted therapies earlier in the disease course, and recognize the importance of controlling disease in terms of controlling outcomes. And I think it's a good problem to have, but one of the problems that we have now is that we have many therapies now approved for ulcerative colitis, and it's getting a little confusing about how to position them relative to each other. And so there's an unmet need in understanding that issue a little bit more.
So I think something of interest, which I always like to have a discussion about, is, it appears, if you look across every trial, and you can almost carbon copy until the more recent ones, sort of what the response rate's going to be, what's the remission rate going to be, and what's the end game, after 52 weeks of treatment, that folks are talking about this ceiling or efficacy plateau. And you sort of started to mention earlier introduction of therapies may help with that. Are there other things, and you're going to talk about sequencing and dive into the network metas and sort of see whether or not we can translate that to the clinic. But what do you see are ways, as we navigate through tonight's presentation, where are ways where we can actually impact this efficacy plateau? And maybe it's beyond starting earlier. Are there other thoughts to share with the audience?
Well, I think part of this is, dose optimization, which of course is more relevant for the biologics. It may be less so for small molecules because their PK tends to be a little bit more predictable, less inter-individual variability. And then I think combinations, or maybe using certain therapies as rapid induction and then leaving other therapies for maintenance. So there may be roles for combinations, and maybe not long-term, but even in the short term for induction, because some of our newer molecules are rapidly acting, and so that there may be some benefits there.
Yeah, so I think you highlighted some key points that we're going to dig into. I think when we think about outcomes, so if we start and talk about current unmet needs related to UC outcomes, let's dive in so we can actually start to see where some of these problems are and maybe some solutions as we get into the data. So if we first want to think about overall, why are we here and why did the therapies that first get introduced in the late 90s with infliximab and then subsequently adalimumab and with 1998 till sort of 2014 before we had another pathway or biologic strategy outside of the TNFs. And so when we look at why is there an unmet need? Well, we know that there's inadequate response despite using advanced therapy, particularly in this particular cohort study published last year. The majority, close to 80%, were TNF exposed, but that also is because of timing of introduction of other therapies along the way, particularly for Crohn's, but also with UC. So the idea here was showing that when you look at everybody, that over time, at 1 year, if we had to give our patients some hope or some North Star to say, this is what we know you're going to, is going to happen in the next 12 months, we saw that the majority, 2/3, were inadequate responders, however defined in the complexities of a retrospective. So let's not ignore the study design, but it's a concept that we're trying to get across here is that inadequate response is real. There are many reasons here. It shows sort of was identified by at least one of the following. If you're not adherent to your meds, if you needed to increase the dose and or frequency, right, because we're not getting advanced therapy at the right level. And you mentioned therapeutic drug monitoring. So that obviously is a big player in our biologics, but particularly TNFs. Also pain medications, surgery for ulcerative colitis. These were all sort of associated with lower rates of response at a year. So interestingly, though, TNF alpha, meaning being on a TNF blockade, was more of a risk factor for inadequate response. But I do think that has to do with the pharmacokinetics, particularly of anti-TNF, versus what we've learned, right, about the non-anti-TNFs, and sort of the pharmacokinetics are not as volatile, shall I say, as with TNFs. And if we have time, we can maybe address that. And so additionally, when we look at probably a bigger problem, which is the next slide, which is focused on the fact that when we look at what is actually happening out there, and I want to focus on the blue graph showing you the adjusted percentage of patients that are steroid-free, the idea that the majority are still on corticosteroids. So what's our definition of success? And I know when people ask our opinion and we look at week 52 remission rates, even when we evaluate clinical trials, we are still saying, I'm not sure a CDAI score in Crohn's disease is what we define as success, meaning just alone without being able to come off steroids, right? You and I have spoken multiple times about the importance of steroid-free clinical remission. And so I think understanding that patients who experience steroids, we need to redefine what is success for our patients and really help them understand that we could do better. And you had mentioned combination a little bit before. So the concept of that's not the combination we're talking about, right? We're talking about biologically combining advanced therapies that can actually address in a non-steroid suppressing way. And I think what is interesting, you mentioned speed. I'm saying you mentioned time to rapidity of onset. I use, the term need for speed, is that the speed at which some of our small molecules are working may even lead us to question, is there really a role for steroids anymore in the face of some of these very, very rapid acting therapies? So we'll get into that when we talk about the data, which is exciting, and hopefully we'll actually even talk further about it. So one thing that we all need to understand about UC, and I think we sold UC a little short, is that we're so focused on irreversible bowel wall damage and Crohn's disease resulting in, resection, and we need to stop doing that, and we need to get effective therapy on board. And that's because Crohn's was a transmural disease and UC is really just a mucosal disease. Well, the data is suggesting that that's not so accurate in our thoughts about it, is that with UC, the burden of untreated chronic inflammation affecting the compliance, for example, the rectum or the left side, the stricturing, the anal rectal dysfunction, the ability of the disease to go from rectal to pan in patients, that being a negative prognostic sign of actually response to therapy, been shown a number of times. So I think we're so focused typically in Crohn's and early that window. And we've seen these slides that have been pretty famously showed at every presentation on the sort of sine wave of the natural history, typically focused on Crohn's. What I love about this paper is it actually draws attention to UC being equally important as having early effective intervention. So I sort of like this concept, and this concept of disease clearance, which is sort of the next phase beyond deep remission, is this concept: can we actually clear the disease? And should we be using a different term when we talk about histologic remission, endoscopic, and clinical remission? And maybe we could start introducing a new lexicon on disease clearance. So that's sort of the next, I think that's the next thing for us to think about. Have we really cleared that biologic presence or biology presence? So that's kind of cool for the future as well. So just to sort of put an exclamation mark on the concepts of early versus delayed initiation. This was published from the group out of Chicago, Noah Cleveland, Dave Rubin, put together this paper looking at the timing of not just, we talked about TNF originally when we looked at all the TNF studies, were like those who got it early, even the Sonic trial was you were within 2 years of getting, anti-TNF. What Noah Cleveland put here in her research is suggesting that when you look at different cohorts and the delayed introduction of vedolizumab, which is in keeping with some of the data from our clinical experience as well. And I think early typically means that it's your first line. So could it be that it's not just that you're delaying in the onset of actually giving therapy, but you failed others? That's potentially a reason why you want to use certain therapies in a certain order. So I'll wait for you to talk to us about sequencing. But this is just making the point that if you wait too long to actually start using effective therapies that are targeted, particularly in UC, then you're really looking at a differential in response or lack thereof. And particularly, you could see the different cohorts. So just to add some additional information to what you were saying about the word early, and I'm giving the opposite, saying that starting late may impact outcomes, right? Okay. So let's now, Ed, I'd love for you to introduce our case study patient, because it's always great for us to show data slides, but in the context of a case, it's probably much more impactful.
Absolutely. Okay, so this is our case. Naomi is a 29-year-old. She was diagnosed with moderate to severe ulcerative colitis about 6 months ago, and she's previously received a corticosteroid taper and then mesalamine. However, over the past 3 weeks, she's had up to 5 bloody stools daily. She's not having any extraintestinal manifestations or symptoms thereof, fortunately. Sigmoidoscopy shows that her Mayo endoscopic subscore is 2, which means she has erosions and or friability, and that's at least moderately active. On her lab test, she has a normal CBC, essentially normal albumin, but her CRP is a little bit elevated at 12 milligrams per liter. Next slide, please. So if you look at the ACG ulcerative colitis guidelines from a couple of years back, they did a neat thing. They applied the old Truelove-Witz criteria for ulcerative colitis severity and tried to map to that several other parameters such as CRP, fecal calpro, endoscopy score, using either the Mayo subscore or the Simon Travis UCEIS index, or ulcerative colitis index, endoscopic index of severity. And I think our patient, Naomi, fits in this moderate category, moderate to severe. She's having blood in the stools frequently. She has an elevated CRP. and she has a Mayo endoscopic subscore of 2. And so she has moderately active disease. And I think, Marla, what's your take on this patient?
Yeah, so I think this is a pretty classic patient we would see. I didn't get whether she had pan or left-sided colitis, so that may impact some ratings of severity, right? But if you go by based on her clinical symptoms and she has an elevated CRP, she automatically meets that at least moderate criteria, which is what you had shown. And I think what we have difficulty with is these patients who are right in the middle, right, Ed? Because we have therapies that are approved for mild to moderate and patients who are approved for moderate to severe. And so I feel sort of bad that moderate's almost like an afterthought because you really straddle sort of different categories. But I think for me, when you start getting an elevated CRP in a UC patient where you think it's more of a mucosal disease,
Absolutely.
it does get me a little bit more excited around that. I think I need to go beyond a 5-ASA. Now, she has 5-ASA and steroids, so she's already sort of been there, done that. And
Right.
So the question is, what's next? And how do you decide what is next? The beauty is, she's not severe in a sense where you have very limited options and you're sort of like, do you earn sort of therapy A? We have a lot of options for this patient. And I love this kind of patient because it allows me to have incredible discussions around risk benefit and explaining what our goals are and how we monitor you. So, in your opinion, what is on the table for you as well? So I noted that I have everything on the table, in my opinion, in this case.
Well, so like the pre-2020 opinion, I'd be thinking veto or infliximab, and then maybe reserve, say, tofa or ustekinumab for second line is typically how I practice. But like you said, now in the last year and a half, 2 years, we have some additional options available. I want to go back to just emphasize a teaching point that you mentioned, the CRP. We all know about CRP responsiveness in Crohn's disease, but you're absolutely right. Mild to moderate UC generally doesn't bump the CRP. So when you start seeing that CRP go up even a little bit in UC, that's a more ominous finding than it is in Crohn's disease. And so it's important for people to recognize that.
Yeah, I think, so if we look at those treatments and just like laundry list, because we're going to be focusing on small molecules tonight, but I think it's always important to remember that approved for moderate to severe, we've got infliximab, we've got 2 anti-TNFs, 2 others, subcutaneously emitters, adalimumab and golimumab.
Yeah.
And we have ustekinumab, and we've got vedolizumab. And we now have those, obviously non-TNF, and now we have ozanimod as well, which is about a year or so, almost a little bit over a year, which was the first small molecule essentially approved without having to fail a TNF. Remember, tofacitinib was approved unrelated to whether you've seen a TNF or not. And then we know the story that the label got changed a few times now. And upadacitinib has that same sort of label restriction about needing to fail at least 1 anti-TNF. So it does push it into a post-biofailure bucket, in essence, right, sometimes. So, that's what we have put it in that order of sequencing, and you're going to talk to that as well. But I think the fact that we have 3 different biologic classes, right? We've got the integrin base, we've got the IL-12/23, and we have the 3 TNFs, does give us lots of opportunity. And now we have the S1P receptor, and we'll get into a little bit more data about ozanimod. And yes, tofacitinib and upadacitinib are also approved. But again, I sort of put that over here for a minute, like to the right.
Absolutely, yeah.
So as we go through, and we talk about sequencing, I'm going to be really curious to know, like, just right now, if this patient was in your clinic right now, instead of talking to me and everybody else, what would be your, gut feeling about what would be your top 2 choices for this kind of patient?
Yeah, I think, again, I've been a big Vito fan for a long time, and Vito would definitely be in the range. I think a small molecule, and that it's that bridge to the moderate patient, and it's like a bridge from 5-ASA to advanced therapies. It fits in between. That might be the way to go.
Yeah, so I think it will depend on preference of how they want to administer a therapy, IV versus SubQ versus oral. You will talk about that in shared decision making, but also just as a reminder, in a female patient, where they are in their child sort of bearing perspective of where they are and what they're thinking timeline wise, that may actually impact our choice. So it's funny, it's like you see data and you're like, we make choices and we look at network meta-analysis, but then the patient's in front of you and everything changes as to, what you're going to talk about. If they have an extraintestinal manifestation, you may say something different. So personalization must be sort of front and center based on that individual, where they are in their journey with IBD and what their goals are. I think also helps us decide what therapy. So let's move to what therapies. So if we look at just as a reminder of the approved and new therapies in UC, conventional, we talked, I wouldn't say that immunomodulators are approved, by the way, but these are the category of what was deemed, I'll be honest, sort of, I think, outdated. Conventional therapy is everything now. There's no real idea of conventional, because I think biologics are conventional. So I think now we've started to see things a little different, but in terminology, we typically say conventional therapy. Even for trials, it's like if you failed steroids, immunomodulators, or aminosalicylates, that would be considered conventional. And then I sort of summarized the biologics that are available in the 3 biologic classes we have, which are here, and then also the small molecules. So I think we did summarize sort of the main categories, and now we're going to dive in a little deeper into particularly the small molecules. So let's talk about ozanimod. We mentioned that last June of 2021, ozanimod was approved for use in moderate to severe UC. There is no sequencing. We don't have to fail sort of a particular TNF, for example, unlike what Ed and I were discussing regarding the JAK inhibitors. And here what we're showing you is, if you look at the induction period, which was a week 10 induction. By the way, every study has a different induction period. So just if you want to, it's hard even in these network metas that we're going to show in indirect comparisons, they have different time points. So we look at induction for ozanimod was at 10 weeks, and showing you here 18% clinical remission, clinical response rates. And then we started introducing, actually, ustekinumab was one of the first to talk about this concept of mucosal healing, which has been updated or upgraded to say endo improvement plus no neutrophils on biopsy, right? This mucosal healing has changed its narrative and has advanced to include histology now. So that is an important teaching point as well. So endo improvement means a Mayo score of endoscopic score of 0 or 1, no friability, just so that we're all grounding ourselves. And then in those that met response criteria in induction, we're then randomized to placebo, re-randomized, because these were all people who received ozanimod induction. So the blue on the top row essentially got randomized to continue on drug or being withdrawn with placebo, which is the gray. So I do also want to, another teaching point for clinical trial design is, unless it's a treat straight through design, which Elevate UC, which is etrasimod, which is the other S1P receptor modulator that we'll be showing you, that was placebo versus drug the entire time in the trial. These randomized withdrawal study means we take patients who are doing well on the drug and withdraw them and put them on placebo. So that's what the bottom row is. And it's just showing you those patients who at the end of induction, at the end of maintenance, were in clinical remission and response. So this would be, for example, response 60% of the 47.8 who were actually randomized, as an example. So keep that into context when you're looking at these re-randomized study design. But showing you again, steroid-free remission, which is what Ed and I were most interested in. The good news is it looks like those that were in clinical remission, The majority were also in steroid-free remission, showing you this mucosal healing concept and maintenance of remission, meaning taking those who are in remission at week 10 and them still being in remission at the end of maintenance. So again, these are new definitions that have come to our lexicon in clinical trials. So it's good to start to see them as we evolve to understanding. So the next slide actually shows you the time to response. And so for ozanimod, we have the data showing you that and remember with ozanimod, actually, there's a sort of a ramp up. It's a starter pack in a way because for heart rate and bradycardia, you go from in a blister pack, sort of you escalate up to the full dose of 0.92 milligrams to be taken after a week. So there really wasn't evaluation in the first week, but this is just showing you the amount of weeks after for both remission and response, showing you essentially what were the separation from placebo, which is the gray bar. So you could start to see where things separate in terms of efficacy, and you can already start to see around week 4, you see a real separation from the gray, which is the placebo arm, from the 2 actual drug arms as it relates to the weeks on treatment. So this is just speaking about the idea that we start to see response, and we need to have patients know that we're starting to see response early. And that's what patients want. Ulcerative colitis patients have urgency, possibly accidents, rectal bleeding, can't get off the toilet in the morning to get to work on time. To me, and Ed's heard me say this, there's an urgency to urgency with ulcerative colitis. And I think understanding that and getting on patients and having them realistic expectation of when we should start to see benefit is really important. So next, looking at, all right, what happens when you're done the blinded part of the trial and you're actually looking at long-term, how do patients do? And here you can see the slide goes out actually to week 94, week 142 of follow-up, and it's pretty durable, as you can see on the top line. Those are observed case. Those are patients who still remain in, and you're looking at those who made it to the end are still doing well, for example, when it comes to response at week 142, which is the darker blue bar. So just showing you this idea that there's durability, and we've known this. And I remember looking at the data from biologics going, if you were good at 6 months, you were good at a year. And if you're good at a year, you're good, long term. There's a lot of this durability. And I think where things may have fallen apart in the biologics is just dosing, right? Particularly loss of efficacy is due to antibody production, et cetera. We don't have that issue with small molecules. So I think that does add another layer that could speak to durability, and that may apply to the non-TNF biologics as well, because their half-lives are very long, and we just don't run into, like I said at the beginning, that sort of volatility of pharmacokinetics, and we don't have to worry about that with the small molecules, which is very nice as well. So next, what we really want to think about is really the safety, because it's impossible for you and I to talk about all the exciting things that are happening when it comes to actually the efficacy of all these new therapies, because these are so many new toys and in our toy box, and we got to learn how to play with them, and which patient is which therapy, which time, and all that personalized precision stuff we really want to get into. But you have to reference it with safety, because I remember when we were talking, and you'd probably remember, there's concept of a patient benefit index. We looked at it in psoriasis. There was a dermatologist who created sort of a patient benefit index. Where did they place priorities in terms of making treatment choice? And convenience, by the way, was very important in psoriasis. And second was safety, and third was efficacy. So you and I probably, and most of our provider friends on the line, are probably very focused on getting you the most effective therapy. But we must balance that with an understanding of safety, because I would tell you that if all our drugs are effective, they're approved, but what stops us from being able to easily or without barriers be able to say, you should get this and it works, and we walk away and we're excited, but there's really a safety discussion that needs to go on. So this is just the long-term safety of ozanimod in patients who enter the open label extension. So important to just think about the long-term safety. So we're keep giving you the most updated data on long-term because our patients know that in 52-week trial, you're not going to see a lot of rare events. You need a longer exposure to be able to see events, particularly those that are rare, meaning less than 1 in 1,000. You and I have given a Cornerstones talk recently suggesting that rare events often could get lost if you're not following them long term. So we're happy to present the long-term data here and showing you the exposure adjusted incident rate, which means per 100 patient years of follow-up, what are the number of events that we're seeing? And this just lists the most common events that you're seeing in the total patients who entered the open label experience, and on the right are those that actually entered in response. So just showing you sort of the totality of the 823 patients. And what you can see here, probably the thing I think that rose to the top when we first started to see JAK inhibitors was zoster. We thought, oh, this is just a JAK inhibitor problem. Well, in the end, by the way, in the mirikizumab study that we presented DDW, believe it or not, IL-23, there was more zoster in drug than placebo. Here you're seeing that about 3% of patients exposed to also ozanimod experienced herpes zoster. And I think you'll agree, Ed, that now that we have the inactive Shingrix vaccine, really at the end of the day, we should probably be thinking about this for most of our patients, not just drug specific, because immune steroids, immunomodulators, I mean, the whole story, we've known around about zoster because we've both used thiopurines forever. So we know this is a thing. So this wasn't sort of something that jumped out at me anymore. I'm no longer following that sort of concept as being something I'm really worried about. Bradycardia is probably the most important adverse event that folks were concerned about with the S1Ps. And what you can see here in the long term, we're talking less than 2% of patients exposed long term to ozanimod, this mechanism of action, S1P, actually experienced a bradycardic event. And to be fair, at 1 year, so looking at baseline when you entered the study to 1 year of maintenance, the mean beats per minute change was 1. So your heart rate, basically your beat per minute change from 0 to fast forward the end of maintenance was 1 beat per minute. So I think important though is that an EKG must be or proposed or recommended to be performed before you do start this class of therapy. So that is something new to us as gastroenterologists, Ed, in terms of something that we're routinely recommending. But I think if we understand the context, we'll be able to communicate better with our patients to let them know why and what the true issues were in the trial, for example, and what we're seeing on long-term exposure. Those to me are sort of, serious adverse events, infection, serious infection. You and I know 3 to 5% is sort of the party line of what we see across most of our therapies. So that again is not anything new. I like to focus on also things that really are barriers to patients wanting to go on to a therapy. And we know that malignancies and infections are definitely high on the list. So I always like to know this data when I'm communicating to patients. And here you can see malignancy and serious infections. So the viewers could actually see what the real data was in the long term. So this is more data that we had before we had the clinical trial. So next, when you think about also looking at other safety adverse events of interest, I like to call them, meaning what do I need to do to monitor my patients in order to make sure that they're safely receiving these therapies, liver enzyme abnormalities, as well as absolute lymphocyte count, just showing you overall that truthfully, a large proportion of patients who entered the open label extension, we're talking 50% of patients experienced a lymphocyte count less than 500. So I think it is important for us to be able to communicate and monitor, probably more than anything, is to be able to monitor these patients closely. And I get asked that a lot because the package insert references sort of how to monitor therapies as well. So if we go on to say, what's the next thing that came into our world over in 2022? Ozanimod was 2021, and now we have upadacitinib, which was introduced March 16th, 2022, as the second JAK inhibitor. It is a JAK1 inhibitor. As a reminder, tofacitinib is a JAK1/3. So this is a JAK1 inhibitor. And this is just showing you the remission and response rates, induction of, and week 52. So you see the clinical remission, for week 8 for the 2 induction trials, which were achieve and accomplish. And on the right is the maintenance data. And it's comparing 15 milligrams versus 30, just so you know, because that's the 2 doses that we used in the maintenance. But in the actual, to be fair, the green is actually 45 milligrams in you achieve and you accomplish. So the coloring's a little bit off. So let's assume that placebo is a light gray. Let's assume very dark would be the 8-week you achieve and you accomplish 45 milligram, and on the right is actually 15 is the lighter green, and 30 milligrams would be the medium green, just to restage. So the coloring's off, apologies. So this is the concept that you see remission rates as such. I will say we've never seen this degree of remission in patients with UC. So keep that in mind. And so next, when we look at maintenance of remission, just to show you some of the key, I showed you the remission rates at week 52. I showed you the difference between 15 and 30. Just as a reminder, the label actually says 15 and 30 can be used in maintenance. They do make reference in the label that more refractory patients may need to be on 30. And also, just as a reminder, that there's only 1 induction dose, which is 45. So there is a de-escalation in maintenance. So here's just showing you that when you keep people on drug versus withdrawing it and giving them placebo, as same mechanism as I showed you for ozanimod, you see that when you take someone who's doing well, which would be week 0, by the way, that's when they began maintenance, which is week 8 of induction, but week 0 of maintenance, things don't go well when you remove effective therapy. Because remember, responders go into maintenance. So everyone was doing really well. They responded. They met the criteria to go and be randomized. And here we are withdrawing drug, which is the gray line, showing you that you do pretty well when you stay on drug. And those are the 2 blue lines. So just showing you a perspective in a longitudinal way to show you what happens and how we started to see separation about 3 months into maintenance for urgency. Urgency began to come back for those people who were on placebo, and abdominal pain actually started to separate from placebo already at 8 weeks into maintenance, which would be at week 16 in total of exposure of drugs. So this is giving you a perspective of when things start to fall apart. But the good news is, in clinical practice, we don't withdraw effective therapy intentionally. And so it's irrelevant to our practice, but just showing you that patients pretty durably have these patient-reported outcome responses over time when they're actually continue on drug. So next, I want to, again, reference, just like I referenced, you can't reference safety without efficacy, just showing you the safety of maintenance therapy with UPA, just showing you placebo, and this is 15 milligrams. And the right there should be 30 milligrams. So just showing you the safety of the therapy across the board. And what I did want to highlight also is the rate of zoster. That, of course, it's around 5%. It's not that dissimilar with what we saw with tofacitinib. And just showing you serious adverse events leading to discontinuation. You see that more folks in placebo typically are discontinued, by the way, in maintenance because an adverse event is worsening disease. So always remember that when you're putting in context of looking at safety. Guess what? When you withdraw drug, you can actually get colonic perforation. And when, so just remember that there's sometimes more repercussions and adverse events when you actually are on a placebo. So just highlighting that and the serious infection rate you can see on drug 3 to 5%. So again, you're able to see that as well. So now, Ed, I'd like to touch on and just remind everybody about cutting up to the minute. We're showing you the data from the 2 UC phase 3 trials that were presented at DDW, and I had the pleasure of presenting the Lucent 2, which is mirikizumab, which is an IL-23 or P19 IL-23 monoclonal antibody for UC. Risankizumab or Skyrizi was approved, as we know, June 16th here for Crohn's disease. But this was the first data on using this target in UC, and every endpoint was met: clinical remission, steroid-free remission. 98% of patients who were in clinical remission were actually steroid-free at 52 weeks total of treatment, as well as endoscopic remission. And this HEMR, which is the histoendomucosal remission, is the same as the mucosal healing definition from ozanimod. So be careful as you interpret, as I said, different definitions, which includes endoscopic response, meaning an endoscore of 0 or 1, without friability, plus no neutrophils on biopsy, which I think is pretty spectacular. And on the right, similarly, balancing safety with efficacy, showing again the fact that we had very few patients discontinuing drug due to an adverse event, less than 2%, and more discontinued to an adverse event in placebo because we withdraw effective drug. Same randomized withdrawal study design I showed you for the others. So the next asset or target that was presented at DDW was the second S1P receptor modulator, etrasimod. And this was showing you both week 12 and week 52, as opposed to all the studies I just presented. This was what we call a treat straight through design. So they used literally from day 1 placebo versus day 1 etrasimod, showing you the week 12 and the week 52 clinical remission, and showing you the key safety events that were reported at DDW. And of course, we'll wait for the full publication to be able to look into sort of what we call table 2 or 3, which would be the safety, just so we can have the balanced discussion as it relates to efficacy. So Ed, I think even though we can have a long discussion around positioning, I think you giving us the data right off the bat, showing us and educating us, would actually help.
Sure. So before I start that, I think the way I think of comparative efficacy is there's like 3 buckets of data that we get this from. And one bucket, the weakest bucket, is observational, non-randomized, retrospective observational studies that try to compare 2 therapies. That's admirable. The biggest flaw with those is that you always are struggle trying to adjust for baseline severity, and there's always hidden biases that you can't completely adjust for. You can try to do propensity score matching, all that, but it only gets you so far. The next level is the network meta-analysis, where you try to use the placebo arm to link together 2 therapies that weren't actually studied in the same trial. And that's a reasonably good way, although there's still limitations there because, again, it's not exactly the same patients. And then finally, the highest level of evidence is the head-to-head trial. And like the best example of that in UC is the Varsity trial, which is vedolizumab versus adalimumab, and vedolizumab had about a 9 to 10% edge. Of course, there were other head-to-head trials with etrolizumab and adalimumab and etrolizumab and infliximab, but those aren't relevant because it doesn't look like etrolizumab is going to be further developed. So we're going to talk mostly about some of these meta-analysis. So could I have the next slide, please? These are the network meta-analyses trying to adjust. And this is actually the most recent one. So that's one of the issues, is that every time new trials come out, these network meta-analyses need to be updated to incorporate the new trials. This one was published in Lancet Gastroenterology and Hepatology recently. And as far as I know, it reflects I guess now that DDW came out, Marla, we have all these additional trials that have to be incorporated, and so we don't have that yet. But this incorporated trials up until like the beginning of the year, And I think what stands out here is that upadacitinib seemed to have, so this sucra value, thinking the closer it is to 1, the more effective the drug is. And you can see that placebo, right, was the worst. It has the lowest rate of, the lowest ability to induce remission or endoscopic improvement. So upadacitinib looked the best. Infliximab also looked pretty good. But then if you go up and look right in there, ozanimod and tofacitinib are there. Ustekinumab right behind that, vedolizumab behind that. So let's think about this. But this is, I think, food for thought. Filgotinib is on there. That's a JAK1 that's approved in the EU, but it's not approved in the US right now. But you can see for endoscopic improvement, the higher dose of filgotinib looked pretty good. Okay, next slide, please. This is looking at the safety end, the same network of meta-analysis updated to the beginning of the year. So the further over to the right the line is, the less safe it would be. You can see that upadacitinib had basically the highest rate of adverse events. But in terms of serious adverse events, etrolizumab and ozanimod were up there. Now, the caveat here is, just like Marla was saying when she was discussing adverse events, in these studies, worsening of the underlying IBD, the underlying UC, is counted as an adverse event. So it's hard to separate out in a table like this which are like the adverse events related to, say, infection or what have you, versus the ones that are related to flares of the drug. Of all the drugs, the one that was the safest, you can see the shortest lines were with vedolizumab. And so that kind of largely fits with what we think about the mechanism of action. And so anyway, upadacitinib had the highest rate, vedolizumab looked the best. Next slide. So this is actually an abstract presented at last fall, and Marla was involved in this abstract. But this was specifically comparing ozanimod to adalimumab in moderate to severe UC. So it's a network meta-analysis, but focusing on those two. And what you can see that in the induction phase, there is a trend favoring ozanimod for clinical remission and response. But for endoscopic improvement, it was definitely in favor of ozanimod. Whereas for the anti-TNF experienced patients, the clinical response was in favor of ozanimod even more. And that kind of fits with what Marla was showing when she was presenting the True North results, where there were some interesting differences with TNF experience. And then in the maintenance phase, again, some trends for clinical remission and response in favor of ozanimod in the anti-TNF naive, whereas in the anti-TNF experienced, it was more across the board. And so there does seem to be perhaps an edge in that anti-TNF naive group for ozanimod as compared to adalimumab. And again, the big caveat here is that it's an indirect comparison, right? This is not head-to-head data. This is based on an adjusted indirect analysis. Next slide, please. And this is looking at ozanimod versus vedolizumab in similar fashion. And basically, I think this is showing that there are no clear-cut significant differences in induction between ozanimod and vedolizumab. In maintenance, most of the endpoints here, there's no significant difference, maybe a trend towards better clinical response and endoscopic improvement with vedolizumab in maintenance. But overall, I would say that the benefit-risk profile would be fairly comparable. Next slide, please. Oh, actually, no, not a next slide. So, Marla, at this point, I mean, what do you think here? Do you think this is, actually, no, I'm sorry. Let's go to the next slide, please. Yes. This is a different network meta-analysis that was presented at ECHO, and this was comparing ozanimod to a variety of different therapies. And again, If the point estimate is to the right of the vertical line, that's in favor of ozanimod. If it's to the left, it's in favor of the comparator. So for biologic naive patients, there were really no significant differences. It seemed like ozanimod was trending in favor of itself over adalimumab, whereas for some of the other comparisons, not as much. And then for the bio-experienced patients, I thought this was interesting. You can see that there were definite improvements in favor of ozanimod over adalimumab, maybe less so for some of the other therapies. So at this point, I'd like to think about our case, Naomi, who was 29 years old, and she had moderate to severe UC. She had tried prednisone, 5-ASA, and was having 5 bloody bowel movements a day. Mayo endoscopic subscore of 2, CRP that was elevated. Marla, what sort of therapies are you thinking about at this point for that patient?
Right. So this is a naive patient who we talked about has moderate 4 to 5 stools. The CRP was our only alarming factor. Of course, we've ruled out any infection. And really, as we talked about, I think it comes down to preference of where she is. I noted about child, pregnancy, and the reason why I say that is because of the very long half-life of ozanimod. It wouldn't necessarily be, if she's planning on starting a family sooner than later, it wouldn't be my first choice, although in someone who wasn't in that stage or era in their disease, it would be on the table. So then really it comes down to, does she want an anti-TNF, vedolizumab, or ustekinumab? I would say at this point, I would say vedolizumab is probably my most go-to, as you had noted, for moderate ulcerative colitis. But if she says, I really don't want to get infusions, I'd say, well, ustekinumab, you get 1 infusion, and then you would get a self-injectable. So that goes into this shared decision-making that we're going to get to. Would you have done something different in this case?
No, I think you're right. I think Veto would have been high on my list. I think right, the informed decision making where we're providing information, letting the patient decide, and maybe who knows, maybe this patient said, well, I really want an oral agent, and maybe she knew she wasn't planning on getting pregnant anytime soon and was willing to go with contraception, then maybe a small molecule would have made sense here.
Yeah. And what if she had failed TNF? I'm just curious so just failed TNF. Yes. What's your next move?
Well, I think there you could go to, and again, it's the pregnancy discussion, but I would, upadacitinib was definitely on the table here. Highly efficacious therapy, and then she would meet the criteria based on the FDA approved indication that she had failed an anti-TNF, and so realistically, I think that would be a reasonable choice.
Yeah, I agree completely.
Okay, so let's go into the next section here. Next slide, please. We're going to talk a little bit about shared decision making. So I've said this before, when I'm seeing a patient, I'm not only trying to diagnose the problem, but I'm trying to diagnose where they are on this scale. And so we're always trying to balance the risk of the disease and its complications and the severity with the risk of treatment, and also taking into account the patient's comorbidities. And patients are thinking along those same lines too, and patients are on different parts of this scale. And so when we're seeing a patient, they have to understand, okay, are they more efficacy driven, or are they more risk driven? And so that plays a role into what we offer. And I think, like Marla said earlier, we have to be very flexible when the patient is in front of us in the clinic. And I don't think dogma works very well when you're seeing IBD patients. They're going to vote with their feet if you're too dogmatic. You can't really, we talk about algorithms, but because there's so many factors involved, we have to take into account all these patients are, right, they're concerned about the risk benefit. They're concerned about the logistics, the convenience of the therapy, the rapidity of onset, and of course, their out-of-pocket costs. And so all those things need to be considered. Next slide, please. This was an interesting study where 200 patients and 200 physicians were asked about different aspects of ulcerative colitis treatments. And you can see that for some, especially the efficacy at 1 year, patients and physicians had exactly the same thoughts, but there were significant differences for some of these others, including concerns about risk of malignancy, risk of serious infection, rapidity of onset, and then oral therapies or dosing schedule. So is it daily or BID or TID? And then there were less significant differences for some of the dosing by sub-Q or IV, and also for the need for steroids. Next slide, please. So again, this is what we do. I mean, we have to provide patients with enough information that they can start thinking about these choices. We have to try to tease out. Some patients already have it figured out what their goals are, what their preferences are. Some patients kind of feel it, but it's hard for them to express, and we have to help them bring that out. We've got to talk through the options, and this takes time. Sometimes, some of these steps don't always have to be done by the main provider. I think an IBD pharmacist is a wonderful help on the team to help achieve some of these goals. And then we have to be in contact with the patient and adjust therapies as needed. And I think if you go through this process, the patient feels much more confident about the drug and is willing to maybe stick with the drug if little hiccups occur. Whereas if they're never quite on board to begin with, they're much more likely to jump off therapy as soon as some little thing happens. So let's go right to the next section. Next slide, please, which is about treat-to-target therapies. And Marla touched base a little bit on this concept of this whole progression of disease severity and bowel damage, and maybe a treat-to-target paradigm is the way to get around this. So let's go to the next slide, please. The idea behind treat-to-target is that we initiate therapy, we reassess with a target or a surrogate marker of the target, we adjust therapy accordingly, and then reassess. And it's a cycle. And by continuing to monitor, we adjust. And the idea is that if we can keep the patient under tight control, in full remission or minimal disease activity, we're going to lower the rate of complications, and we're going to improve the natural history. And in the case of biologics, especially TNF, that part of that tight control is by checking the therapeutic drug monitoring and making changes accordingly. It's less of an issue with the oral therapies, and it's somewhere in the middle for the non-anti-TNF therapies. And don't forget, if the patient achieves tight control and stays in that, we can maybe consider de-escalation of some of their therapies in the future. Next slide, please. The STRIDE-2 panel was an expert consensus panel building upon STRIDE-1, which was STRIDE-1 was sort of identifying the targets, and STRIDE-2 is more trying to determine the sequence of the targets, the short-term versus the intermediate goals, and also a recognition that there are surrogates and perhaps the importance of fecal calprotectin as a surrogate marker for inflammation in ulcerative colitis. But I think one of the goals here is to not just get the calprotectin down, but also to achieve endoscopic healing, and also a proposal to consider histologic healing as a long-term target. And on that note, next slide, please. This is an interesting study from the University of Chicago looking at a large proportion of patients who were on therapies, and you can see that the patients who were in complete histologic remission did the best. They had the lowest rate of relapse, whereas the patients who had ongoing inflammation did the worst. The patients who achieved a little bit of histologic improvement did somewhere in the middle. But ideally, we want to, to really, really deeply improve outcomes, we probably have to get closer to that histologic healing, which, again, easier said than done, but it's an important recognition. Next slide, please. And of course, this is a classic study from the Ibsen cohort in Norway, looking at patients, stratifying them by whether or not they had achieved endoscopic healing at 1 year, and then looking at rates of colectomy. And there were some big differences over time. The patients who had achieved endoscopic healing at 1 year had a rate of colectomy of only 15%, and it was much, much higher in patients who had not. And so at a minimum, I think endoscopic healing is important. And I think of endoscopic healing as if you're getting the Mayo endoscopic subscore to 1 or 0. That's basically endoscopic healing. And I think that's a minimum target. And, we can debate about the histologic deeper targets, but something to think about. So I'm going to turn it back to Marla to sort of summarize our discussion today.
Wonderful. Thank you, Ed. That was great. I think we sort of went through this journey of understanding that we can do better, and patients are still on corticosteroids, even on advanced therapy, understanding the new small molecules that are available, talking about where we want to place these drugs and how to think about them, recognizing they're not perfect, these comparisons, as you noted, and then thinking about we must include the patient in our decision and what our ultimate target. So that's like a whirlwind view of IBD from end to end. So the key points that just to highlight are advances in medical therapy really have enabled us to target better outcomes for patients. We're talking about UC tonight in terms of long-term outcomes like complications, hospitalizations, surgery, and of course, overall quality of life. We do know, as I noted, that there are, despite having really this arsenal of therapies for UC, we still keep facing very similar problems of lack of steroid-free, and we really haven't been sort of, I think, reached our plateau or broke through the ceiling of the efficacy plateau like we talked about with some solutions. We know that early is critical and may help prevent progression and irreversible bowel wall damage that we should be thinking about for UC as much as Crohn's. And we know that there's a whole spectrum of therapies now. I never thought I would say, like, within X amount of years, we have all these new therapies for UC. I really, it's amazing. This year's been amazing. Last year was amazing. And the next year is going to be equally as amazing for UC and Crohn's, by the way. And with the, expansion really, as I just highlighted, of the therapeutic landscape, although it does come with it greater opportunity to start using precision medicine, we must understand when therapies do best when used first versus second, and start to understand the context of sequencing, and I think, and precision and personalization. I think that's what the next 5 years is going to be about, and really understanding how we can target our patients' biology to the therapy, because we do have many now, and be able to really ensure we are focused on patient benefit when we're making treatment decisions. So, Ed, I really want to, thank you so much for joining me tonight and for really giving us all these insights. Any thoughts on sort of these key points that we want to leave the listeners with tonight?
Well, I think that the main thing is, listen to the patient and work with the patient. And by getting their buy-in, you're going to get a better outcome. They're going to get a better outcome, more importantly. And it is great that we have all these therapies. And there are some nuances, but the more options, the better.
Yes. Thank you. And it's an exciting time, as we all agree here. So to the audience, I really want to thank you so much for spending part of your evening with us. Please make sure to claim your CME credits by completing the post test and evaluation form at integrityce.com/IBD post eval. That's a mouthful. And I want to thank you again and wishing everybody a wonderful evening, and look forward to seeing you in person or through this portal again, hopefully soon. Thank you, Ed. Thank you, everybody.
Thanks, Marla. Enjoyed it.